Okay, the second day of gastrointestinal disorders, we're going to talk about stomach disorders. Mainly, the PANS blueprint includes gastritis, gastroparesis, peptic ulcer disease, neoplasm of the stomach. Even though neoplasm is not in the PANS blueprint, we're going to go over them. And pyloric stenosis will be covered in the pediatrics module. So we will talk about acute and chronic gastritis and make difference between them, the importance of Helicobacter pylori, gram-negative bacteria implicated in most of the pathology of the stomach, including peptic ulcer disease and gastric cancer. We're also going to go over peptic ulcers disease and other syndromes that are characterized by high excretion of acid. Also, a little bit about gastroparesis, and the last one, the two types of gastric cancer. Let's start by defining what is gastropathy and what is gastritis. Usually, we refer to gastritis to an acute inflammation of the mucosa. And when we talk about inflammation, we do need histopathology workout that is called a biopsy. Gastropathy refers more for a chronic problem because after the damage of the epithelial cells, there is regeneration, and sometimes it has minimal inflammation. So the etiology for gastritis can be divided in gastropathy. Usually when we talk about a chronic problem is because of the use of a drug or alcohol. And in this case, the drug usually is the non-steroid or NSAIDs. Also, there are other etiologies for gastropathy, like ischemic disorders due to burns, sepsis, hypovolemia, or vascular disorders, like portal hypertensive or gastric ectasis. So, on the gastritis side, usually when we talk about gastritis, we talk about Helicobacter pylori or infections etiologies. But on the other side, we have autoimmune gastritis. So those are the most main causes for gastritis. Depending on the time, usually an acute gastritis can start from 2 days up to 10 days. It is an acute problem and it's associated with local irritants to the mucosa or to the endotoxins due to bacteria, alcohol, or aspirin or NSAIDs. Chronic gastritis, on the other side, we're going to be seeing erosions and manifestations of a chronic changes. So it takes more than days, it takes months, even years. We're even going to see atrophy of the glandular epithelium in the stomach. So this is our main character today for stomach. It's called Helicobacter pylori. He likes to adhere to the epithelium mainly on the gastric surface. And this microorganism is very difficult to eradicate. It can survive for years in the stomach of a person. It affects worldwide people, 2/3 of the world population, and it is implicated in chronic inflammatory disorders of the stomach. Um, Helicobacter pylori has a transmission uh, called fecal oral route, and usually goes from the epithelial cells of the cervix into the gastric pits. Um, it has two main locations. It could be located on the antral part of the stomach, or it could go and progress into the whole part of the stomach body and fundus. That's called a pangastritis. The problem with Helicobacter pylori is that it will induce the G cells or the gastrin producing cells to produce acid, and also the parietal cells to produce acid. But with time in that infection, the acid production will fall, and then it will continue with an atrophy or with an intestinal metaplasia in the duodenum. So Helicobacter pylori will also facilitate the progression of the bacteria, that infection will facilitate the migration of that bacteria from the antrum to the corpus of the stomach. So when the person is has the infection with Helicobacter pylori for a long time, it will use a lot of pump inhibitors products like proton pump inhibitors as medication to reduce the acid, the excess of acid. That plus the infection with Helicobacter will contribute to the production of hypochlorhydria, meaning low acid levels. The infection with Helicobacter pylori will attract neutrophils induced by interleukin 8 and the release of oxyradicals, also infiltrations of lymphocytes, and also Helicobacter will progress and colonize the gastric body. After that, duodenal ulcers will be typical associated with antral gastritis, whereas in contrast, gastric ulcers and gastric cancers are typical associated with a more extensive gastritis. Also, after a more extensive gastritis, that will go to an intestinal metaplasia located in a duodenal, also duodenal ulcers, and lower normal or reduced gastric acid secretion. And we'll go over that when we talk about cancer, stomach cancer. Okay, so we can have patients that have no symptoms or moderate symptoms of dyspeptic or and with or without peptic symptoms. We can have patients with hypochlorhydria. We can have patients with acute gastritis, also with chronic gastritis. The infection of Helicobacter pylori can start in childhood and it progresses through the decades up to a patient can evolve into an atrophic gastritis. And there is a gene called cytokine-associated gene A, or COC-A, that it is a potent inducer of inflammation, and it's a gene that can correlate with the gastric cancer development. Also, chronic gastritis due to Helicobacter pylori has been associated with dyspepsia and with the development of peptic ulcer disease, and other chronic complications can be atrophy, intestinal metaplasia, gastric cancer, and also mucosal associated lymphoid tissue lymphoma. Gastropathy, apart from Helicobacter pylori, we can have gastropathy due to the use of NSAIDs. These will cause the inhibition of prostaglandin synthesis. And remember that prostaglandins is implicated in the maintenance of the protective mechanism of a gastric mucosa due to the injury of the hydrochloric acid. The autoimmune metaplasia is a result of autoantibodies against the mucosa. So the oxyntic mucosa is where the parietal cells are located in the stomach, right? So usually it will lead to atrophic gastritis in the body of the stomach and reduce or absent of acid or peptic production due also to in the loss of intrinsic factor. So autoimmune metaplasia, atrophic, it's a chronic gastritis and it's called a MAG. The AMAG, or autoimmune metaplasia atrophic gastritis, has different symptoms and it progresses in time. One of the main symptoms that we're going to see is vitamin B12 deficiency anemia, or known as pernicious anemia, due to the deficiency of intrinsic factor. So in the AMAG, we can have also hypergastrinemia, iron deficiency anemia, antibodies against the parietal cells or the intrinsic factor, and vitamin B12 deficiency. Patients with autoimmune metaplasia have a higher risk for gastric adenocarcinoma. So let's do a summary about gastritis. First, we talked about that gastritis usually is a pathology that is acute. Gastropathy, it is chronic. And inflammation will be present more in gastritis and chronic manifestation in gastropathies. The main cause of gastritis is going to be an infections agent called Helicobacter pylori, but we can also have gastritis immune mediated, like the one that we autoimmune mediated, like AMAC. The diagnosis for those patients usually has to be based on biopsy and on histologic findings. And the histologic findings can reveal epithelial hyperplasia with minimal inflammation for gastropathy or with high inflammation for gastritis. To determine the underlying cause will help us make the better choice of treatment. Like, for example, for Helicobacter pylori, we need a triple treatment. Gastroparesis, it's a syndrome that is characterized by the delay of the delay of emptying of the stomach due to mechanical obstructions, and the main symptoms are going to be nausea, vomiting, early satiety, belching, bloating, and upper abdominal pain. The gastroparesis etiologies can be divided of what part of the neurology of the nerves is implicated. Remember that the GI and the stomach is innervated by the autonomic nervous system, by parasympathetic nerves, sympathetic nerves, but also we have internal or primary internal nerves inside the GI. Any one of those can be affected, like for example in diabetic neuropathy, parasympathetic, sympathetic, and also the enteric nerves inside the GI. Any one of those can be affected in the case of the diabetic neuropathy. The most common cause for gastropathy are going to be diabetes or the use of medication or post-surgical procedures. Talking about what medications can delay the gastric emptying, one of the most common one that I'm sure you have been heard about is glucagon-like peptides, Ozempic, Mounjaro, Zepbound, or any of those analogs that will lower patients' weight, but also one of the main effects is delaying the gastric emptying and producing gastroparesis. But of course, narcotics, opioids, alpha-2 adrenergic agonists, calcium channel blockers, dopamine agonists, tricyclic depressants, muscarinic receptor antagonism, and others like cannabis can also produce gastroparesis. In patients with diabetes, as I told you, the intrinsic or extrinsic neurons or the interstitial cells cajal can be affected, and also the impairment of contractions in the stomach. So remember that the stomach has different type of contractions that goes from the fundus through the body and up to the antrum part. Any one of those can be affected with diabetes. There are also infiltrative disorders like systemic sclerosis that can be a problem with those low intensity amplitude antral contractions, and also when we have gastric resections on patients, the facet of contractility and also the movement and accommodations of the stomach can be impaired. Let's change subject to peptic ulcer disease. And the picture is showing a duodenal ulcer. Ulcers can be located in the duodenal, which is the most common one, but also in the gastric mucosa. What is a peptic ulcer? It is an ulceration that goes up to the internal muscularis mucosa. It's like a hold. And the problem with the peptic ulcer is that it can bleed and produce upper bleeding of the GI or lower. But if it progresses over the muscular layer, it can perforate and produce the death of the patient. Peptic ulcer disease is very common. 1 case per 1,000 persons per year. In the general population, it's a lot. Usually increases with age, both of them, duodenal ulcers and gastric. The prevalence in young people has declined, but in older people has raised due to the use of anti-inflammatory drugs like non-steroidal anti-inflammatory drugs, NSAIDs. Ulcers related to NSAIDs has increased, and also the use as aspirin as a medication to lower the risk of strokes and MIs. So it's more prevalent in male in the Western countries, and also the rates of incidence of peptic ulcer disease varies within the presence of Helicobacter pylori. Of course, the rates of infection of Helicobacter has been higher in developed countries, and of course, peptic ulcer that is related with that infection also has raised. So we have a high prevalence of Helicobacter pylori, and that Helicobacter pylori infection affects and contributes to the gastric acid secretion, and it lowers the mucosal defense mechanism. And globally, that prevalence has been higher, and in the United States, it's around 37% of people is infected with Helicobacter. So also NSAIDs, including aspirin, is associated 4 times more with peptic ulcer disease. So when we ask about risk factors for peptic ulcer disease, you should talk about Helicobacter pylori, NSAIDs, and aspirin. An ulcer that is induced by NSAIDs is more refractory to a conventional therapy. Now, other risk factors apart from Helicobacter pylori, aspirin, and NSAIDs is the use of alcohol and also the use of smoking, of tobacco. Do we have genetic factors? Of course, first degree relative with a peptic ulcer disease is a risk factors. There are other risk factors due to groups of blood, immigrants from a developed country, nation like Japan, African American, Hispanic ethnicities, and others are sleep apnea, COVID-19, psychological factors, and there's others also. But the most common one that I want you to remember are Helicobacter infection, NSAIDs and aspirin, and some other medications. Okay, here is the complete list of etiologies and diseases associated with peptic ulcer. In the drugs, apart from NSAIDs, we have several other drugs that you can see here, like corticosteroids. Do not forget that. Chemotherapy. Do not forget that. Okay, comorbid ulcers associated with descompensated chronic disease or acute multi-system failure. Remember that patients that are in the intensive care unit tend to develop stress ulcers. Okay, what is the pathophysiology? So we're going to start here with the most common causes, Helicobacter and NSAIDs. Here I am showing the mucosa with the epithelium, lamina propria, and musculari mucosa. So the ulcers goes up to there, and after any event that will trigger the production of a peptic ulcer disease, usually there is an imbalance between those factors that protect the mucosa and those factors that destruct the epithelium and the mucosa. And usually occurs a defect that will extend up to the musculari mucosa. And once the protective superficial mucosal layer is damaged, the inner layers are going to be susceptible to the acidity produced in the stomach, and the ability of the mucosal cells to secrete bicarbonate becomes compromised. And also, if we have an infection in a colonized Helicobacter pylori in the mucosa, in the epithelium, that will cause inflammation. One thing that I want you to remember is that Helicobacter pylori is going to impair the secretion of bicarbonate directly and will also promote the development of acid HCl increasing the acidity and also producing a gastric metaplasia. So the progression of that will produce or a gastric ulcer if we have a pangastritis, or if the colonizing of the Helicobacter pylori is located in the antrum, we will have mainly a duodenal ulcer. So let's go back and review a little bit about the anatomy and the areas of the stomach. We have here the fundus, the corpus or body of the stomach, that is also called the ocentic gland area where parietal cells are located. And we have then the antrum. Well, the G cells or gastrin cells are located. Also, the somatostatin or D cells are located mainly in the antrum. The D cells produce somatostatins, and somatostatins are inhibiting gastric acid. Parietal cells and G cells are parietal cells directly are implicated in producing HCl, and gastrin, through the stimulation of the parietal cells, also are implicated in the productions of HCl. So in the stomach, we have the gastric pix, and inside the gastric pix, we have parietal cells, which are the main producers of HCl, lowering the pH of the stomach and activating pepsin enzymes produced by the Schiff cells, and pepsinogen will transform in pepsines, and pepsines are enzymes that will process proteins. Also, parietal cells produce intrinsic factor important for the absorption of vitamin B12 at the level of the ileum. The other cells are the enteroendocrine cells, also located in the pits, gastric pits, and they are going to produce histamine. Histamine is going to stimulate parietal cells to produce HCl. And we have the G cells producing gastrin, and also gastrin is going to be activating HCl secretion. HCl secretion is also produced by the direct stimulation of the vagus nerve using acetylcholine. And then we have the D cells producing somatostatin that inhibits the HCl release. Okay, do we have difference between duodenal ulcers and gastric ulcers? Absolutely. The duodenal ulcer, which is one of the most important ones causing mortality in patients, are going to be located in the first portion of the duodenum, and it's going to be characterized by high levels or hypersecretion of acid. It's associated with the infection of Helicobacter pylori in the antrum. So it's going to be an antral predominant gastritis. Somatostatin is going to be decreased, and because it's decreased, gastrin is going to be increased, and also the acid. Gastrin levels are going to be usually elevated. We're going to have an impair of bicarbonate secretion, and the injury of the duodenum is usually to the presence of acid in the duodenum. It should not be there. And also, after eradication of Helicobacter pylori, there could be a recurrence of the disease. And also, if we do have duodenal ulcers in patients that are not infected by Helicobacter and they do not use NSAIDs, those cases of duodenal ulcers are going to be produced by those syndromes of acid hypersecretion that we're going to talk in a little bit. Zollinger-Ellison syndrome is one of those severe acid hypersecretion syndromes that are going to be associated with duodenal ulcers. In the case of the gastric ulcer, less common, it's going to be located in the body or in the distal antrum. Normally, the acid secretion can be increased, but it could be normal. It's associated, if it's associated with infections of Helicobacter pylori, it will be characterized by a pangastritis. Somatostatin levels can be reduced. Gastrin levels can be elevated due to low levels of somatostatin, but bicarbonate secretion usually is normal. Gastric metaplasia is not defined in this. There's no gastric metaplasia. Post-eradication, usually we can have recurrent of hypersecretion. Usually is less common, is not related with non-pylori and non-ensites. It's less common. And Zollinger-Ellison is a rare cause. It does not usually produce gastric ulcer. So the hypersecretion environment occurs in the following conditions: Zollinger-Ellison syndrome, which is the most important one, but it can occur as systemic mastocytis, an elevation of mastoid cells, cystic fibrosis, a genetic condition, hyperparathyroidism, or Angel's cell hyperplasia. So in the case of Zollinger-Ellison syndrome, this is a syndrome that it's going to be characterized by hypersecretion of acid by the stomach, but also by diarrhea. It has an incidence that could be rare, 0.5 to 2 per every million people. Usually it's between 20 to 50 years old, more prevalent in males than in female. And also it could be 70 to 100% of the patients that have a Zollinger-Ellison syndrome, it's going to be associated with MEN1 type endocrinology syndrome, and they will have a duodenal gastrinoma. So a gastrinoma is a tumor located in the duodenum or in the pancreas that will produce excess of the gastrin. And we have endocrinology syndromes called hereditary endocrinology syndrome called MEN1 or MEN2, 2A and 2B, and we're going to go over that when we get to the endocrinology module. That it is related with Zollinger-Ellison syndrome. So what happens here? We have an excessive production of gastrin by the gastrin cells. And gastrin will affect the production of HCl over the parietal cells, stimulating the production of acid by parietal cells. But also gastrin will also affect the production of histamine over the ECL cells, and the histamine produced by the ECL cells will also increase the production of parietal cells, a gastric acid. So here in this picture, we see that the mucosa has an abnormal thick gastric compartment because of the excess of parietal cells producing acid. So gastrin stimulates parietal cells largely via the release of the histamine through the ECL cells. So the excessive gastric secretion produced by a gastrinoma will result in high gastric acid up to 4 to 6 times or over 10 times due to the trophic action of the gastrin on the parietal cells and on the histamine secreting enterochromatomorphin-like cells like you see here on picture 1. So why do we have diarrhea? Well, we have some pancreatic digestive enzymes that needs a pH to be alkaline. When the pH lowers and it's acidic, it will interfere with those enzymes produced by the pancreas, and it will interfere in the emulsification of the fats by the bile acids. Also, it will damage the epithelium of the duodenum and the villi, and by those two phenomena, we're going to have
of maldigestion and malabsorption of the fats, and that will produce the presence of fats in the feces, and that's called steatoreas. Also, excessive high levels of gastrin will inhibit the sodium and the water in the small intestine, and it will produce a secretory diarrhea. And that's why we have diarrhea. Let's change subject and go to gastric cancer. So we have two types of cancers. The most common one that I'm going to talk in a few minutes, it's more common in males in the fifth decade. The less common is frequent in younger patients in both sexes, but it carries also a worse prognosis, and that's the diffuse one. Usually, the cancer is present in the lesser curvature or in the junction, in the esophagogastric junction in our Western countries. In the case of Japan, which is one of the countries with more gastric cancer worldwide, and also Peru, in Japan is located in non-proximal. It's a non-proximal gastric cancer. In the USS and other Western country, usually it's a proximal gastric, so it's close to the esophagus in the lesser curvature also. Japan has, because of his higher prevalence and incidence in gastric cancer, has a better prognosis, diagnosing and also treating gastric cancer than the US. The risk factors include nutritional factors such as dietary components of nitrosos or high salt preserved food, also smoking, low levels of vitamin A and C, consuming large amounts of smoke or cured food, and we in Texas, we love smoke food, but it causes cancer, gastric cancer, a deficit refrigerated foods, also contaminated water. And here are the two types of cancer. So we have the intestinal type gastric cancer. This is the one that is more prevalent and occurs in 50 and above years old, is typical sporadic. It does not have a gene. The onset is later. After 50 years, it has a better prognosis, and usually it starts with a gastritis, then an atrophy, then an intestinal metaplasia, then a dysplasia, and then the adenocarcinoma. It is related to the infection or environmental factors and the infection of H. pylori, or the risk factors that I talked about. It has a gland-forming histology. The prophylaxis goes within the eradication of H. pylori, and it is 1 in 39 of patients that has intestinal metaplasia, and 1 in 19 with dysplasia will develop cancer within 20 years. So this cancer can be prevented and can be treatable. It's going to be more sensitive to the action of chemotherapy like 5-fluorouracil and oxaliplatin, and also it's strongly associated even 6 times higher for risk cancer if the patient has an infection with H. pylori. In the case of diffuse type cancer, it is related with genetics, CDH1 gene, and it's autosomal dominant. It's hereditary diffuse gastric cancer, HDGC. It appears in patients earlier, around 38 years, is highly invasive and has poor prognosis, does not have precancerous lesions. The main risk factor is going to be the mutation over the gene CDH1, and females can also have risk for breast cancer. The histology is characterized not by gland, it's cohesive seals very different from the gland forming of the other one. Prophylactic is recommended if there is a mutation to have a complete gastrectomy before age of 30. It's going to be more resistant to treatment, and it's not associated with H. pylori. And this is just a general information about gastric carcinoma. Maybe we can make a difference knowing this, because right now we need to ask for diagnosis in those patients due to the autonomic dominant inheritance of gastric carcinoma in younger patients, not only for the mutation of CDH1, but also for but also for the HER positive gene, positive due to metastatic adenocarcinoma, and basically located in the gastroesophageal junction. It is recommended for all patients right now due to the possibility of better treatment with some specific chemotherapy combination. And this is now due to a research, international clinical research. Now we need to ask for the human epidermal growth factor receptor 2, also for gastric cancer. And that's all for today. Thank you.